Well, that's an excellent question. And really, the conversation with patients should be that there have been 3 clinical trials that have been conducted to try and assess the value of chemotherapy in the setting of men who present with newly diagnosed metastatic hormone-sensitive prostate cancer. In looking at how chemotherapy was traditionally used in men with prostate cancer, it was really used in men who had failed hormonal therapy, and that was how docetaxel, for example, got its original indication. But now there have been 3 new studies looking at the use of chemotherapy at an earlier time in the disease process. So men who present with newly diagnosed metastatic disease are all potentially candidates not only for androgen deprivation therapy, or hormonal therapy as a lot of people like to call it, but also chemotherapy. The problem is that all men who present like this are not created equal, and there are differences, and some of the studies had differences in terms of the way patients were identified, the way that their disease state was actually assessed. So I'll just give you an idea. The most common study that we look at in the United States was called CHARTED. And in that study, they did divide men up into high volume and low volume metastatic disease. Those who had high volume metastatic disease, defined as 4 or more bone metastases with one outside of the axial skeleton, or soft tissue involvement such as liver, lung, those patients considered high volume did seem to have a dramatic response to the addition of chemotherapy over just hormonal therapy alone. In the patients, though, who had lower volume disease, small number of bony metastases, no involvement of any other areas such as the lung or the liver, their benefit was really not seen. So it's a subset of the patients. About 2/3 of the patients had this high volume disease, about 1/3 of them had this low volume disease. But in that study, where they did do that sort of parsing of different presentations, there was a difference in high volume, but not in the low volume. So getting back to the original question, if I were to have a patient who presented with low volume disease, I would let them know that in general there could be a benefit, but the study, at least the United States charted study, did not support that. There have been some other studies, such as a French study that showed no benefit, and then there was a European study called Stampede. It didn't divide patients up like that. So there is some potential use of chemotherapy, but there are side effects and harms to the chemotherapy. So what usually we try to do is do a more measured approach to those patients that have low volume disease and hold the chemotherapy in those who don't respond to the traditional hormonal therapy. So it's not like it's an all or nothing decision. It's really just one of timing. And so I believe that in men who progress through the hormonal therapy, even with low volume disease at presentation, at that point where they seem to be failing, they would be reasonable candidates for chemotherapy.